Hi guys, this video is about hypermetropia. So this is somewhat opposite to myopia. So I would recommend watching this after watching myopia video. Here also we will study under definition, etiology, components, clinical features, complication and then management. Coming to the definition, here the parallel rays of light from the infinity focus behind the neurosensory retina. So in myopia it was in front of the neurosensory retina. Here this will focus behind the neurosensory retina provided the accommodation is at rest, and since they are passing the neurosensory retina, the image will be blurred on the retina. Coming to the etiological classification, here also it is ACIP, that is axial, curvatural, index, positional and aphakia. Axial means here the axial length, AP axial length is shortened. So in myopia it was elongated, here it is shortened, and 1 millimeter shortening will give plus 3 diopter hypermetropia. And then curvatural means the cornea or the lens is flattened, while in myopia it was becoming steeper, here it is becoming flatter, and 1 millimeter increase will give plus 6 diopter hypermetropia. Now coming to index hypometropia, here what is happening is the lens refractive index is decreasing. In myopia, the lens refractive index was increasing in case of nuclear cataract, that is nuclear sclerosis, while here it is decreasing, and it is seen in all days, that is type of cortical sclerosis, and also in people of diabetes under treatment. So that is index hypometropia, the refractive index is decreasing. Now coming to positional one, where there is posterior displacement of the crystalline lens. In myopia it was anterior dislocation, while here it is posterior displacement. And also aphakia, this can be congenital or surgical aphakia, that is the absence of crystalline lens. So since lens is not there, there can be high hypermetropia, because lens is the one focusing it in retina. If lens is not there, no one is there to focus, so it will focus behind the retina. So that is aphakia. Now coming to the unique part of hypermetropia, that is the component of hypermetropia. So actually there is total hypermetropia is equal to latent hypermetropia plus manifest hypermetropia. So total hypermetropia means it is based on the ability of accommodation to correct the error. So that is total hypermetropia, that is equal to latent hypermetropia plus manifest hypermetropia. Latent hypermetropia means it is the portion of error corrected by the inherent physiological tone of the ciliary muscle. So our ciliary muscles will contract for the accommodating power of the lens. So it is latent. And this has to be revealed by cyclophysics to abolish the tone. So while we are going to correct the hypermetropia, we have to see this latent hypermetropia. So in order to see this latent hypermetropia, we have to abolish the tone of the ciliary muscle. And abolishing can be done by cyclophysics like atropine, so that the ciliary tone is gone, and then we can see the latent or the hidden hypermetropia. The next one is manifest hypermetropia, that can be facultative or absolute hypermetropia. So manifest means the remaining portion that is not corrected by the ciliary tone. So some portion will be corrected by the ciliary tone. So abolish it and look at it to find out the latent one. And the remaining portion that are not corrected by the ciliary tone is known as manifest hypermetropia. This can be facultative and absolute. Facultative means these are corrected by voluntary accommodative effort. If we voluntarily do the accommodation, it can be corrected. And absolute means it is not corrected even by voluntary effort. So this was not voluntary. This was by the inherent tone. Latent was by the inherent tone of the ciliary muscle. While in manifest, the facultative is by the voluntary effort. And absolute means it is not corrected even by the voluntary effort. So that will lead to blurred vision. This is components of hypermetropia. So total hypermetropia is equal to latent hypermetropia plus manifest hypermetropia. Manifest hypermetropia means facultative, that is correctable by the voluntary accommodation, while absolute not correctable by the voluntary accommodation. Now coming to the clinical features. So the common symptoms are, first it can be asymptomatic, okay, that is in young, low error, there is no symptoms, people will see as normal as they are. And then there can be asthenopia. What is asthenopia? There will be eye strain, frontal headache and watering while doing the near work. So a person is trying to read, he will start getting frontal headache, he will start getting watering in the eye and also eye strain. So that is asthenopia. And then there can be defective vision. So it will be near vision that is defective. In myopia that was far vision that is defective. Here initially it will be near vision, but when the person grows older or in higher degrees of hypermetropia, there can be distant vision affected also. Then there can be pseudomyopia, that is due to the intense ciliary muscle spasm. Due to excessive accommodation, there will be intense ciliary muscle spasm, and that can lead to myopia, that is known as pseudomyopia. So it can be a symptomatic asthenopia leading to eye strain for a headache and watering doing near work, and distant vision. Initially near vision will be defective, then the distant vision can become defective, and pseudomyopia due to intense ciliary muscle spasm due to excessive accommodation. Now coming to the signs. So here in the anterior segment examination, we can see what? Short and shallow eye. So we can see a short and shallow eye. Short and shallow eye means eyeballs will be small. In myopia, it was prominent eyeball with long axial length. But here the eyeball will be small and the anterior chamber will be shallow. So in A scan, we will get the axial length is just less than 22 mm. There it was more than 26 mm. But here in A scan, we will see that the axial length is small, eyeballs are small, and also the anterior chamber is small. And this shallow anterior chamber can predispose to angle closure glaucoma. So the chamber can get closed all at once, and that can result in angle closure glaucoma. So hypermetropia is a predisposing or risk factor for angle closure glaucoma. So in anterior segment, we show small eyelid and shallow anterior chamber. Coming to the posterior segment, that is less specific. Here in the fundus, what we can see is the optic disc is hyperemic with blurred margin. So we can see the optic disc is hyperemic with blurred margin, and this will resemble papilledema. In retinal disorder, we will see papilledema. So this hypermetropia also resemble papilledema, but it is pseudopapillitis. It is not a true papilledema. It is pseudopapillitis. That is, here there is only optic disc hyperemia and blurred margin. There is no venous engorgement, no hemorrhage, no exudate, no blood vessels, and the blind spot is not enlarged. No venous engorgement, no hemorrhage, no exudates, and the blind spot is not enlarged. Only optic disc hyperemia and blurred margin can be seen. So that is pseudopapillitis. In retina, we can see short silk appearance. Okay, so this was about the signs. That is the anterior segment, we can see short and shallow eye, and the posterior segment, look for the fundus, where we can see optic disc is hyperemic with blurred margin, pseudopapillitis, and retina having short silk appearance. Now coming to the complication. So there can be recurrent styes and blepharitis in the eyelid due to the associated with constant or chronic rubbing and congestion. During near vision, what will happen? There will be eye strain, frontal headache, and watering. So we will rub the eye. Associated with chronic rubbing and congestion, there can be recurrent styes and blepharitis. And then there can be accommodative convergent squint, that is esotropia. There will be a convergent squint. This is due to excessive accommodation and convergence. For reading near things, what will we do? We will do excessive accommodation because we have hypermetropia, things are blurred. So we will do excessive accommodation and convergence, which will result in squint, convergent squint. Then there can be amblyopia, especially in childhood. If the hypermetropia is uncorrected in childhood, that can lead to amblyopia, ametropic amblyopia. Then there can be primary ankle closure glaucoma. As we mentioned, they have shallow anterior chamber, so they are predisposed to ankle closure glaucoma. So recurrent styes and blepharitis, accommodative convergence squint, amblyopia, and primary ankle closure glaucoma. Now coming to the treatment, there can be optical correction and refractive surgery. So optical correction means we are giving the spectacles. Here we are giving convex plus lenses to converge the rays, and children with convergent squints should be corrected with cycloplegic correction to prevent amblyopia. So we are giving convex plus lens, and children with convergent squint should be given cycloplegic correction. And coming to the contact lenses, this is for high error cases and also for cosmetic correction. That is, spectacles may be cosmetically bad. So for cosmetic correction, we will give contact lenses, and also for anisometropia, we will give contact lenses. Now comes the refractive surgery. Here again there is corneal and lens based refractive surgery. Corneal refractive surgeries are hyperopic LASIK surgery, conductive keratoplasty CK or LK, that is laser thermokeratoplasty. So which are the corneal procedures? Hyperopic laser, conductive keratoplasty CK or laser thermokeratoplasty LK. And lens based procedures are phakic IOL, refractive lens exchange, that is RLE. So phakic IOL or RLE. So this was all about hypermetropia, somewhat opposite to myopia. So watch myopia also with this for the complete study. So thank you.